Hi, my name is Melinda, and today I'll be talking to you about frontotemporal dementia, otherwise known as FTD, and specifically the behavioural variant of the disease. As it's a behavioural variant, you'll see that a lot of the symptoms are behavioural in nature. So the individual will start to experience changes in their personality. They might start acting in socially inappropriate ways and not being in control and be able to regulate their emotions as well and how they're relating to others around them. They might demonstrate some apathetic behaviours, not wanting to participate in activities they normally enjoy. Their ability to participate in goal-directed behaviour is often reduced, and they might also be disinhibited and they have reduced inhibitory control, so spending money, um, having sex with random people, a little bit sort of like mania of bipolar disorder. They start behaving very erratically. This apathy, this aspontaneity and indifference is obviously a marked difference to how the person would normally behave, to the person that would normally be acting. So there's a marked difference um, with these patients. These behaviours are not normal for them. The person might also engage in repetitive behaviours such as foot tapping. These symptoms might start off not as concerning, but they progressively get worse over time, and the person often isn't aware of their behaviour, their actions. One thing to note is their cognitive ability remains intact. So the core features for diagnosis is early decline in social interpersonal conduct, impairment in regulation of personal conduct, loss of insight, so that self-awareness is lost, and emotional blunting. So the main words you can see here are social, emotional, personality. That's what this disease affects. So what are the diagnostic criteria and known pathology? The neuropathological classification is based upon misfolded protein aggregates within the brain. So you can see the protein within the brain. Focal atrophy of the orbitomedial frontal and anterior temporal lobes is also noticed. And this protein we've mentioned accumulates. You'll see that protein within the brain and that frontotemporal lobar degeneration. Now, for diagnosis to occur, the patient must meet at least 3 of these 6 criteria. So there's early behavioural disinhibition, early apathy and inertia, loss of sympathy or empathy, early perservative, stereotyped or compulsive behaviours like the foot tapping, hypoorality or dietary changes. So the person might change how much they're eating too much, eating very little, eating strange things. And these neuropsychological profile deficits on executive function, but memory and visuospatial skills are often not involved in FTD. So here's a table. These are international consensus criteria for BVFDT. These obviously must be present and show progressive deterioration of behaviour and or cognition by observation or history. So there's different categories. There's possible, probable, definite, exclusion criteria, and additional features. And as we discussed, 3 of the features must be present for possible diagnoses. What tests can we do to better understand this? So we can run a neuropsychological battery of tests. to see these changes in personality and behaviour, we can go to the family. Because patient insight is a little bit limited, those interviews with the family become vital. We can also do a frontal behavioural inventory with the family, which is like a 24-item questionnaire for the caregivers across a 4-point scale. The BV DVT Criterion Consortium must meet, as we said, 3 of the criteria. And not just that, but also show significant functional decline in day-to-day lives and that evidence of that frontal and temporal atrophy occurring. So the atrophy in the frontoinsular structures of the salience network, voxel-based morphometry and cortical thickness mapping can reveal selective atrophy of the anterior cingulate and frontal insular cortices early on. Now, these functional neuroimaging studies help also distinguish FTD from Alzheimer's. A recent finding is the von Economo cells are often depleted in patients with FTD. These von Economo cells are crucial in social cognition. So this structural and functional neuroimaging data is now included in the diagnostic criteria for FTD. Here's an old scan from 1999, so it shows how far we've come in imaging this disease. This patient here has FTD, and you can see the atrophy occurring across from 1991 in A to 1996 in B, and again in 1998 in C. How do we distinguish BVFDT? So half of the patients diagnosed, firstly, with a psychiatric illness because of the symptoms are behavioural or social in nature or emotional. It's often misdiagnosed with bipolar or schizophrenia or depression because the symptoms are similar. Unlike depression, which comes along with sadness and suicide, the apathy that occurs in FTD does not have those characteristics. The condition does have some overlaps with motor neuron disease, about a 10% comorbidity. And as we discussed before, FTD can be mistaken for Alzheimer's disease, but there is a difference. The difference is in memory, and visuospatial is preserved. So memory and visuospatial is more preserved in FTD than in Alzheimer's disease. So here's some disorders with similar presentation to FTD. There's neurodegenerative diseases such as Alzheimer's disease, Huntington's disease, and Lewy body dementia. Also psychiatric disorders, bipolar disorder, major depression, and psychopathy. There's also neurological disorders, so vascular accident and traumatic brain injury can present similar features to BVFDT. The main controversy surrounding BVFDT is the diagnosis of the disease. It's difficult to diagnose because obviously the symptoms line up with these other diseases and disorders. So patients are often misdiagnosed with these before they get to a diagnosis of BVFDT. Having that misdiagnosis is a big problem because to get to an accurate diagnosis is usually quite a slow progress. And as we said, this illness is a progressive disease. So as the symptoms are progressing, the patient is not getting a correct diagnosis. That makes treatment also delayed. And as you can probably understand, if the diagnosis is wrong, the treatment doesn't occur, and the patient suffers from this. So accurate diagnosis and recognition of BVFDT within clinicians is vital to understanding more about this disease. Here are the references that I used, and if you want to know more about living with this disease, there's a video here about a person who cares for someone living with FTD to give it more of a humanistic approach. Thank you very much and have a good night. Goodbye.